session, which is the session of deformities and open fractures. We have 4 speakers and 6 panelists from different Egyptian universities and from Jordan and from UK. The first speaker will be Professor Abdeslam Eid, Professor and Dean of Zagazig Faculty of Medicine. It's a great honor to be with us, Professor Abdeslam. Professor Abdeslam Eid will speak about open forearm injuries.
Assalamu alaikum. It is my honor to be with you, sir. This is a very outstanding event, very impressive activity as we are used to from you and from the Benha Orthopedic Department. I'd like to welcome my colleagues in the board of the Egyptian Orthopedic Association, namely معالي الوزير عادل العدوي والدكتور محمد الشافعي هم اللي أنا شايفهم قصادي دلوقتي. Also the staff of Benha University Orthopedic Department بداية من حضرتك وكل الزملاء all the attendants and speakers from Egypt and from abroad. My talk today is about a peculiar case of open forearm injury, and Khalid, you can start the video, please. This is an open injury of the forearm which occurred to a 20-something male due to a shotgun blast. As you can see, there is massive soft tissue injury of the ulnar and dorsal aspects of the forearm, together with a comminution of the middle third of the ulna. Although no X-ray is available, I can tell you that the radius was intact. There was no injury to the radius. Also, there were no any major blood vessel or neurological injuries. So what do you propose we do for such an injury? We did the standard protocol of wash with a huge amount of saline, debridement of all the necrotic muscle tissue of the wound edges, removal of loose bone fragments and the foreign bodies, and we did minimal internal fixation using K-wires and cerclage for the ulnar fracture. So do you suppose we could, in such an injury, close the skin defect, or should we, from the start, go for some form of plastic reconstruction or early coverage? This is what we were able to do. This is because there was actually no skin loss or very little skin loss. The skin was all there, only the blast of the shotgun displaced the wound edges, but we were able to approximate the wound edges with little or no tension, save a small area about 1.5 by 1.5 centimeters. Again, I'd like to ask you if you think this repair will hold in subsequent dressing and subsequent visits. After a few sessions of dressing, at about 2 weeks, we were happy to see that most of the wound healed uneventfully, save a small area of about 4 by 4 centimeters, which was also covered by nice-looking granulation tissue. This was planned for plastic reconstruction, probably by a split-thickness skin graft. However, because the patient refused to perform the plastic reconstruction by skin graft and preferred to continue dressing, he obtained this magnificent result as the skin healed by secondary intention, and there was no plastic reconstruction done for this part. Still, we had 2 main problems. One of them was the non-union of the ulna because of the bone defect. The other problem was because of the soft tissue massive injury, there was loss of finger extension when the wrist was in the neutral position. This was due to the loss of the musculotendinous units of the finger extensors, not because of a nerve injury. So how do you propose we deal with these 2 problems? First, the bone problem was the easier one to solve. We did plate and screws with bone graft, and this actually healed well, and the ulna healed well, and there was no problem with the bony healing. What about the loss of finger extension? When we looked at this picture, we thought that it looked like posterior interosseous nerve injury. In posterior interosseous nerve injury, there is loss of finger extensors, although the wrist extensors are working. So we supposed that we could treat this problem using some form of tendon transfer that we use in radial nerve or posterior interosseous nerve injury. In the brand transfer, we use the pronator tears to restore the ECRB wrist extensor. We use the flexor carpi radialis to restore finger extension. We use the palmaris longus to restore thumb extension. However, we had no problem with thumb extension or wrist extension, so we only transferred the flexor carpi radialis to the extensor digitorum communis to restore finger extension, bypassing the destroyed area of the musculotendinous units of the extensor digitorum communis and avoiding the need to perform more complex reconstructive procedures. This is the final result. The patient is very happy and very satisfied with the procedure. Thank you very much.
Thank you so much, Professor Absalam, for this very interesting talk. Thank you so much, sir. Now we will move to the next speaker, Professor Adel Khamis. Professor Adel Khamis from the Military Academy.
Now we are talking about the combined approach of lengthening and mechanical axis deviation of the lower limb. We know that combined lower limb shortening and mechanical axis deviation is a common clinical problem that may occur either pathological or post-traumatic. Associated shortening may be functional or anatomical. Choice of the most appropriate method for deformity correction plus or minus limb lengthening require accurate assessment of the deformity and measurement of the true anatomic shortening. So, according to the criteria of the deformity and the measured anatomical shortening, we have three choices: either acute deformity correction, or gradual deformity correction, or gradual deformity correction plus lengthening. We should start in every case with this formal regimen. First of all, we have to do the malalignment test to assess the deformity. In this example, we can find that we have an obvious varus femoral deformity. Assessment of this deformity, we should measure the angle of the deformity and the site of the chora in both anteroposterior and lateral planes. In this example, we can find a deformity of 25 degrees in the AP view and of 20 degrees anterior bowing in the lateral view. So we have to conclude these 2 degrees into one angle, which is called the true angle of the deformity, and to set the plane, the exact plane of the deformity. We can use this schedule for that. So we have 25 degrees in the AP view and 20 degrees in the lateral view. This measures 30 degrees in a plane of 52 degrees. The second step and we have to determine and estimate the height of the base of the wedge-shaped diastasis formed in the zone of the corticotomy for reduction or restoration of the axis. We also rely upon this schedule. In our example, we have a deformity of 30 degrees, and the zone of corticotomy at the site of the cora measures 4 centimeters. So, to correct a deformity of 30 degrees in this zone, we have to open a wedge with a base of 2 centimeters. And now we are talking about our golden rule. Acute correction of the deformity is justified if the base of the wedge is not more than half the diameter of the bone at the site of the corticotomy. In this example, we have a 4 centimeters diameters and 2 centimeters the base of the wedge, so we can do it acutely. In this case, the second step is to measure the anatomical length or the anatomical shortening if present. This can be achieved by measuring the anatomical axis of both segments of the bone, above and below the core. In this example, we can find that we have a just simple deformity anteromedial bone of the femur without shortening. So we can correct this deformity acutely using an intermedullary nail, and this is we have done. The second example shows a much more deformed femur. We can measure with the same way, we are following the same steps. We can find a true angle of the deformity is 40 degrees in an oblique plane of 56 degrees. Returning back to the schedule, we can find 40 degrees, and the width of the bone at the site of corticotomy of the cora is 2.8. That's to say, the height of the wedge-shaped diastasis that should be done for correction of that deformity exceeds 1/2 the diameter of the bone at the site of corticotomy. So, acute correction is not justified by opening the wedge. We may do neutral wedge in that case for acute correction, or we may apply the method of gradual correction and open and wedge. In this example, we did gradual correction with open wedge. The hinges are mounted exactly at the apex of the deformity on the convex side of the bone at the site of the cora. Now we have to measure the rate of loosening of the nuts at the leading rod. This can be calculated by this formula: T equals small t divided by I over D. Small t refers to the rate of moving, or the required rate of moving of the fragments apart on the concave side of the deformity. I means the distance between the leading rod and the apex of the deformity, or practically the side of the hinges. D refers to the width of the bone at the site of corticotomy. So, applying this formula, we to move the bone at the concave side of the deformity apart for 1 millimeters per day, we have to move to lose the nuts at the leading rod by a rate of 2 millimeters per day. These can be divided into 2 or 3 times per day. Another example of combined deformity and true lengthening. For simultaneous correction of the deformity and restoration of bone length, we have two basic methods. The first method, we put the hinged units mounted on the threaded rods at the level of the deformity apex, as usual. A lengthening is achieved by tending the nuts of the threaded rods with hinges and on the leading rod. That's to say, we do lengthening or we do loosening of the nuts at the two sides, at the leading rods and the rods carrying the hinges that is mounted at the apex of the deformity. The second method, we can put or set the hinged units 1 to 5 centimeters distant from the apex of the deformity, and extraction is performed in the leading rods as usual. And the first technique that's called monolocal distraction osteogenesis, a daily rate of loosening of the nuts on the leading rod is calculated for gradual deformity correction. The daily rate of loosening of the nuts at the apex site of the deformity on the hinges is calculated by the following formula. TW means the rate, S means the required amount of lengthening, T capital, the daily rate of turning the nuts at the leading rod, and A is the height of the wedge-shaped diastasis. For example, if we are going to lengthen this bone by 5 centimeters, so the S can be 50 millimeters. Okay, and T is a daily rate, consider it 2 millimeters per day. Again, S is 50 millimeters and A is 1 millimeter per day. So if we can use this formula or this equation, we can see that we are going to lose the nuts at the leading rod by 2 millimeters per day and lose the nuts at the rods carrying the hinges by 3 millimeters per day. The second technique is applied for cases with greater deformities, accompanied by small shortening. The distance B to which rotational axis of the hinges has to be moved from the apex of the deformity, calculated by the following formula. We know that the classic traditional way of deformity correction without lengthening, we should mount the hinges exactly at the apex of the deformity. In this method, we put the hinges at the site of the cora, but we move it laterally or medially distal, apart, away from the apex of the deformity by 1 to 5 centimeters. This method, we cannot do it for so much lengthening because we cannot move the hinges more than 5 centimeters. Otherwise, we cannot obtain adequate stability for the frame. We give an example of a deformity, true deformity of 45 degrees and shortening of 4 centimeters. We have to put the hinges 5.2 centimeters away from the apex of the deformity. We do the same evaluation of the deformity, the true angle and true plane of the deformity, and the radial shortening. In this example, we don't have radial shortening because he is a chondroplegia, and we have total shortening or short stature. So we don't have an exact number or exact distance we have to lengthen. So in this example, we are going elective to correct this deformity and lengthen the bone by 4 centimeters. We have to be very precise because we are going to do this procedure bilaterally, and if it's not done precisely we can make length discrepancy. And this is the final shape of the bone after correction and lengthening. And we can see that the child is very happy with the result. We could restore the mechanical axis of the tibia and lengthen it by 4 centimeters. Actually, it's more than 4. And this to compare pre and post-operative photographs. The same principles can be applied for correction plus or minus lengthening of biapical or triapical or multi-apical deformities. Thank you very much.
Now we will move to the third speaker, my dear brother, Professor Ahmed Alam from Benha University, in a very interesting talk. Professor Ahmed?
Yes.
Welcome.
Bismillahir Rahmanir Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. How are you, everyone? Is it shared, Dr. Muhammad?
Yes, sir.
Is it clear?
Yes, sir.
Okay. First of all, I would thank all the participants, the speakers from everywhere in the world for their being with us today. We are honored to have them with us today. I want to thank all my colleagues in Benha University for their effort for having this successful meeting, and a special big thanks for my dear friend and colleague, Muhammad Al-Ashhab, for his great effort for making this meeting very successful, very brilliant, and very magnificent. Thank you, Dr. Muhammad. This is a 15 years follow-up after a novel operation for congenital radioulnar synostosis in a series of 43 limbs. I have nothing to disclose. This is the Nile, the magnificent river. Beside it, it is Benha University Hospitals and Faculty of Medicine, where I work, and many of cases in this series are done at that place. The first case was presented as a case report in the same Benha clinical meeting like this one today with Egyptian Orthopedic Association, but on year 2006. It is about 15 years ago. First case was presented as a case report. And with having 7 operations, it was presented at Russia at SME meeting 2008. These photos were taken by my dear friend, Dr. Saad Gaballah. He is with us now. He is the one who took these nice photos. As a background, congenital radioulnar synostosis or CRUISE is a rare disease, most often proximal, fixing the forearm in pronation. 1/3 of cases is bilateral. Familial predisposition is frequent. The most with several centimeters of fusion with malformed proximal radius. Radius is longer and larger than the ulna with increased its anterior arch. It is a banana-shaped bone. Facial tissues are short, their fibers are abnormally directed, interosseous membrane is narrow, supinator muscle may be abnormal or even absent. Verki type 2 radius is fairly normal, but its proximal end is dislocated either anteriorly or posteriorly and is fused to the proximal ulnar shaft. However, this fusion is neither nor extensive nor intimate as in type 1. It is the mild form. It is concluded that congenital radioulnar synostosis is difficult to treat. Many techniques have been tried in an effort to restore forearm rotation by separation of bony fusion and interposition of something, whatever muscle, fat, fascia, prosthesis, but refusion of the radius and ulna was almost inevitable. Sometimes there is no rotation possible, even after the radius and the ulna have been separated and the interosseous membrane have been split throughout its whole length. That is because of the extensive soft tissue involvement, bony abnormalities present, and the post-operative scarring of the procedure done. So, all previous trials have not been successful in obtaining improvement in forearm rotation. And it was concluded by many authors that it is inadvisable to perform many hoping to obtain pronation and supination, or what recommended is to do nothing for synostosis itself, but just to do derotational osteotomy to position the forearm in a functional position to assist in hygiene with no change in the range of motion. This could be done through or distal to the synostosis mass via a single or double osteotomy achieved acutely or as two-stage procedure or gradually with the Elizarov method, with common complications including nerve injuries, vascular compromise, compartment syndrome, loss of derotation, decreased elbow range of motion, a lot of complications. So a new technique in the form of one-stage intervention, including first step, separation of the bony fusion. Second is a special cementation technique of one of the separated bones. Third step is a special osteotomies for the radius and the ulna. In little details, separation of the bony fusion by a direct small incision over the subcutaneous border of the proximal ulna. The site of synostosis is exposed and the two bones are separated to have one bone as complete as possible at the expense of the other bone. As you see in these photos, this is a pre-operative photo. This is the ulna preserved and the radius suturized. Second step is to cement one of these bones. The suturized bone, we make it with a good rough bed with few millimeters depth, with few drill bits to have good cement incorporation, and the bone is cemented in a way to make it as smooth as possible. In one photo here, the radius is cemented, in the other, the ulna is cemented. Waiting for cement to settle and harden. Of course, we need a very little amount of cement for this technique. The remaining part of cement, we can use it to do something beneficial like this. The third step is the osteotomy. For the radius, we do double osteotomy to correct bowing and malrotation. Radius is divided into 3 parts by 2 osteotomies. This is a derotational realignment osteotomy. This improved alignment makes the interosseous membrane less dense due to obtained parallelism. For the ulna, it is a single, simple derotational osteotomy. The 3 osteotomies are done percutaneously or through a small skin incision, and the intramedullary K-wire is introduced for fixing the osteotomy, and the forearm is forced into neutral rotation to break the osteotomies over the K-wires and put in above elbow cast in mid-prone position. These are the drills for the osteotomy, one of these osteotomies. With 27 cases, this technique was presented at the American Academy meeting on 2015. The patients are 43 limbs in 31 child, age from 2 to 10 years, Cruz Velke type 1, all the severe type with fixed full production deformity, all were managed by the same technique. Like this case, 3 years old with bilateral affection. This is X-ray of the right and left limbs. This is a failure of hand-to-mouth function because of the severe pronation deformity. These are the tricky movements done by the shoulders and the elbow to compensate for pronation deformity. This intraoperative photo for the right lower upper limb. This is synostosis before separation. As you see, the head has no radius, the radius has no head. This is a synostosis after separation and suturization of the radius. This is the radius cemented. This is intraoperative passive rotation to show how much passive range could be obtained before osteotomy. As you have a younger child, you can have a little passive range of supination and rotation. It is evident here by the interosseous space widening or narrowing during rotation. But if you have older children, you don't have this range because of the adaptive shortening of muscles and the fixed contractions of soft tissue and bone. This is the same child after 5 years. This is active supination. About the results, radiologically, bone healing of the all osteotomies was obtained. Bone healing occurred in an average of 7 weeks. Delayed union of 8 ulnar osteotomies occurred, but united finally. Clinically, Excellent significant passive range, about 155 degrees in average, and the active about 115, was obtained final assessment with no significant complications or recurrence of synostosis after a follow-up from 11 to 17 years. About complications, I have 44 minor complications. This is about 1 complication per patient, namely delayed union of ulnar osteotomy, KOR loosening, mild deep tract infection. This is a case to present. This is a preoperative clinical appearance and X-ray. Is a child 4.5 years old, left upper limb affection, severe fixed pronation deformity. This is immediate post-operative X-ray with the ulna cemented and the 2 bones became parallel now. This is 8 weeks post-operative X-ray. 1 year later, this is active near full range of forearm rotation. 3 years post-operative, the same patient, still having the same good active range. This is over the head and the mouse to hand and the hand to mouse function. This photo, you can't do this except you have an active supination. This is hand to mouse function pre and before. The same child about 6 years later. And after 16 years now, this is the same patient with the same range of motion, active range of motion and function. To conclude, excellent passive and active functional range of forearm rotation could be obtained with this technique. No significant complications or recurrence of the synostosis were detected after an average follow-up of about 15 years. Thank you very much for your attention.
Thank you so much, Professor Ahmed Alam, for presenting this novel technique. Thank you so much, sir. Now we will move to the last speaker in this session. Professor Ashraf Obaidat from Jordan will speak about a very interesting topic, which is tendon transfer 5 years after rest drop in fracture humerus. Professor Ashraf.
Bismillah ar-Rahman ar-Rahim. I am Dr. Ashraf Obaidat. I'm a consultant orthopedic surgeon, hand and sport surgeon from Jordan. It's nice to meet the Egyptian Orthopedic Association alongside with the faculty of the Benha University. If we can start the recorded video. Thank you very much. Meet all of you with respected surgeons from all over the world. I would like to thank Dr. Muhammad Al-Ashhab for this invitation. Of course, the Egyptian Orthopedic Association alongside with the Orthopedic Department of Benha University. I'll start this presentation. It is a case presentation for one of my patients. This patient is a 32-year-old male patient from Afghanistan. This patient was involved in a gunshot injury 5 years ago of his right dominant hand. There was an open fracture of the humerus along with a cut of his radial nerve. This patient's job was a carpenter, and actually he was unable to work because he suffered from a complete loss of his right wrist and hand function. This is the pictures before surgery. As you can see here, there is a loss of wrist extension, loss of fingers extension at the level of metacarpophalangeal joint, and the thumb is lying inside the palm. When we are planning those kind of surgeries, it's very important to decide before surgery which tendons you are going to transfer, what tendons you want to transfer to, and what kind of function you are going to restore. Here we are going to restore the wrist extension, finger extension, thumb extension, and abduction. The techniques of radial nerve tendon transfer there are a lot of techniques actually, but here I am talking about the technique where a pronator teres is going to be transferred to extensor carpi radialis brevis, palmaris longus to extensor pollicis longus to restore the thumb extension, and flexor carpi radialis tendon to be transferred to the extensor digitorum communis of the index, middle, ring, and little finger to restore the thumb extension. During surgery here, this is the transfer of flexor carpi radialis to the 4 tendons of extensor digitorum communis. I use the 3-0 ethibond suturing here and the pulver-taft suturing technique. When we are going to transfer this tendon here, we will put the fingers in slight extension, not too much extension, because you need excursion, and you need also the physiotherapist after that not to be difficult for him to move the fingers. Here you can see we do rerouting of the extensor pollicis longus to the flexor side here, and we attach it to the palmaris longus with the same suturing technique. In this picture here, this is the transfer of the pronator teres to the extensor carpi radialis brevis, and this is after the surgery. As you can see, the wrist extension is restored to neutral position now. There was wrist drop. After surgery, directly before applying the above elbow back slab, you need to be sure that the wrist is in neutral position. We started the follow-up after 1 week. We do dressing. As you can see here, the wrist is in extension, the metacarpophalangeal joint in extension, and also the thumb is outside of the palm. After 2 weeks, I changed the above elbow back slab into below elbow back slab with a position of the wrist in extension in neutral position, the metacarpophalangeal joint in extension, and the thumb in extension. After 4 weeks, I removed everything. Sutures is removed, the cast is removed, and physiotherapy is started. Here, after we remove, as you can see, there is a very good healing of the wounds. The thumb in extension, metacarpophalangeal joint in extension, and rest in a neutral position. It's very important here to start the physiotherapy protocol as soon as possible. This is the key point of this surgery. We will talk about the surgical technique in the coming slides, but here, after surgery is very important, even more important than the surgery itself, because the physiotherapy should be started as soon as possible to have a very good outcome. Some surgeons, they start the physiotherapy in 6 or 8 weeks. I started the physiotherapy in 4 weeks, and the physiotherapist started to address the flexors and the extensors, because we need a very good flexors to have a very good extension at the wrist, fingers, and thumb, and also the range of motion exercise. Here is a video here about the thumb extension after directly 4 weeks after we remove the cast. You can see here, this is very good extension over the thumb and the fingers, and the wrist in a neutral position. And here, as you can see, the opponents, it's very important because he's a carpenter later on, because we need to teach him the screwing and everything. And here you can see the finger extension. Yeah. Here you can see the screwing. Now he started to use the screwing. It's very important to have a good extension over the thumb, very good extension also over the index finger to do this motion. Also, we started to teach him the hammering technique. Since he's a carpenter, he needs to use hammer. You can see here, he's using a hammer. This is only after 8 weeks of surgery. Yeah, imagine if we started to do the physiotherapy after 8 weeks, what the patient will lose. This is in 8 weeks. This means he started physiotherapy since 1 month. And we can get this result if we started the physiotherapy as soon as possible. This is 10 weeks after surgery. The patient is able to write and using the pen. The difficulties during surgical technique, here we have 3 points, actually, not 2, like only 2. The pronator teres harvesting. The pronator teres tendon is attached to the periosteum of the radius. So when you want to strip the periosteum from the radius, you need to strip it from the wrist side and upward. It's very important to be very careful in stripping the periosteum, because the periosteum is very weak. And if you didn't harvest it in a good way, you will have a short tendon. If you have a short tendon, it will be very difficult to transfer it to extensor carpi radialis brevis, and you will have a surgical technique problem during the surgery. Either you have to change the plan or you need to do something else. But this is one of the surgical difficulties. The pulver taft also technique of suturing. You need to have the correct instrument. You need to have a sharp, small instrument to pierce the tendon and not to rupture the tendon. The other thing is the exposure. It's very important to have a very good exposure. Some of the surgeons, they don't want to open a big incision. Big incision is very important in this surgery. I saw some surgeons, they take, instead of taking the flexor carpi radialis tendon, they took the median. This is a catastrophic problem, actually, during doing this surgery, to harvest the nerve only because you don't have a very good exposure. Very good exposure will let you see the anatomy in a very good way. As a conclusion, wrist drop and loss of finger extension is very debilitating to the patient. We are using our hands in our daily activity and in our job also. So this kind of surgery, it is a simple procedure with a huge outcome. It is a life-saving procedure for the patient in terms of regaining function and going back to the normal life. So this kind of surgery, it is simple surgery if you know the principles. It is simple if you are careful in doing the technique and you are doing a very good exposure and early physiotherapy. Thank you very much for attending this lecture, and thank you again for giving me the opportunity to participate in this important international meeting. Thank you everybody for listening. Thank you very much.
From Jordan. Thank you so much, sir. We will allow 5 minutes for from our dear panelists for discussion with our eminent and distinguished guest speakers, because we have to stick to the time of the schedule. Any questions to our speakers?
Assalamu alaikum. Thank you, Professor Ashab, for your kind
Professor Hisham Al-Ashri. How are you, sir?
Assalamu alaikum. How are you, sir? Thank you very much. May I congratulate you for that wonderful international meeting.
Thank you, sir.
A wonderful effort as usual, sir. My question is directed to Professor Alam for his very, very interesting procedure for the superior ulnar synostosis. I just wanted to ask him, what is the maximum age allowed to perform this procedure? Because we know that some patients don't present very early while in their life. So till which age can we do this procedure for them?
Okay. Welcome first, Dr. Ashri.
Thank you, my dear neighbor.
About the age, you have to that you have two things or two outcomes from the technique. First outcome is to have an active or functional range. Second outcome is the hand positioning. As much young as the patient is, you can have a good range. The oldest age I did for such cases is 11 years, but with less much active range of motion. Even the passive motion is less. But up to 5 years or 6 years, you still have little adaptive shortening of the pronator quadratus, little deformity at the inferior radioulnar joint. You still have a functional, not full, a functional range at the wrist, at the forearm. But if you have older child, you will only redirect the hand. You will have the hand inspiration, but more or less fix it. But to have a functional range, active and passive, you should have a younger child, maximum up to 6 years. But children with 2 years, 3 and 4, having excellent range. As you go up, you have decreased range. I have cases done with no range. They are 12 and 13 years old, but I patient first that you may not have any active range or passive. You may have only a redirectional, and unfortunately, this was the case.
But doing the operation in a very young age, like 2 or 3 years, wouldn't that make the bones are very short and tiny, actually, to do the combined procedure, proximal osteotomy and then osteotomy of both bones. Would that be, I think, technically very demanding to do it in young children?
It is technically demanding, yes, that's right, but gives you the best results, the best union time, the best condition of the muscle and joint and interosseous membrane, all are in the earliest condition before any adaptive shortening, before fibrotic changes take place. It is technically difficult, yes, but is more better for the result.
Thank you, Professor Alam.
And there is
Thank
no
you very much.
contraindication for an earlier age. Thank you, sir.
Thank you so much, sir.
Thank you.
We can allow another question if any one of our professors has a question. Just one question.
I have a question to Professor Abdelam.
Saad, how are you?
How are you, sir? I have a question for Professor Abdelam Eid.
اتفضل يا سعد.
معالي العميد، كل سنة وحضرتك طيب.
طيب يا حبيبي.
هو I have just a question. يعني it's usual in this such severe injuries to do debridement, massive debridement of muscles and soft tissue, and primary closure, or maybe let the wound open for some days and do more than one debridement. As we know, there is mechanical, chemical, thermal injury in gunshot injuries, and I'd like to know your preference in such these injuries. Thank you, sir.
Thank you for the question. Actually, you inspect and examine the wound, and you deal with what you find. As I told you, the skin was all there. I just needed to pull the skin edges a little bit, and I found that it could be closed primarily. The skin itself looked healthy. The underlying muscles, we debrided all the necrotic muscles. I agree that you have to take a second look, and we did just that. We did a second look. There was no problem. Third look, no problem. So the wound continued to heal. What I need to send as a message from such a case is that you don't sacrifice unnecessarily soft tissues that you will need to reconstruct later. There is no reconstruction that can approximate such a result. If you keep the normal skin, this is greater and better and more cosmetic than any reconstruction that you may do. So you try to preserve the skin, you remove just 1 millimeter from the edge of the wound as little as you can. And of course, you remove all the necrotic muscles, all the bone loose fragments, and the shotgun pellets that you can remove. Of course, you cannot remove all shotgun pellets. Some of them you have to leave in the wound. And then you inspect, as you said, second look, third look. If all is going well, you continue. If there is need for further debridement, you can do just that.
Thank you so much, sir. And thank you so much, our guest speakers and our panelists, for joining us in this